So as Renata said, you heard from Piers Patton yesterday about CLL in the frontline setting. And this morning, first of all, I'm going to talk about CLL in the second and further on lines. So relapsed CLL, the choices and considerations we have available there. And if you joined in yesterday, you'll have been able to see that we've obviously had a new BCSH guideline in CLL earlier on this year. I'm going to talk about the evidence we have for using novel agents in the relapsed refractory setting, how to sequence the novel agents in the relapsed refractory setting. I've put a question mark there because it's not a clear or exact science. Allogeneic bone marrow transplant, should we still be thinking about that in relapsed or refractory CLL? And what do we do when the novel agents that we already know about and have easy access to have been used up? What can we do next? So in terms of considerations, I think the first thing to think about if you think you're dealing with a patient with relapsed refractory CLL is, do they definitely need treatment? So just thinking back to the International Workshop of CLL indications for treatment. And just as in treating frontline CLL, patients where you're seeing evidence of progression after a previous line of therapy don't necessarily need treatment, unless of course they've got troublesome B symptoms or rapidly progressive or symptomatic lymphadenopathy or pancytopenias. So just think, first of all, they may well have progressed after their previous line of treatment, but do they definitely need treating now? The second thing to think about, and this is obviously at any line of treatment, but particularly as you move through the lines of treatment, because Richter high-grade transformation of CLL does become more common in later lines of treatment rather than in treatment-naive patients. So do think, could this be a Richter high-grade transformation? And the sort of things that might give you a clinical suspicion of this would be if there's been a very rapid clinical progression, a very rapid clinical course, or very prominent constitutional or B symptoms, fevers, weight loss, night sweats. If there's a high LDH or asymmetrical lymphadenopathy, so if the patient seems to have one set of nodes or one nodal area that's growing much quicker than other nodes, that might make you think about a high-grade transformation in that area. If you've got a clinical suspicion of Richter transformation because of one of those reasons we've mentioned, then do think about a PET scan. A PET scan is not an absolute in Richter's transformation. It won't give you an answer. You will need to do a biopsy to make a definite diagnosis of a high-grade transformation. But a PET scan with an SUV reported over 5, along with a clinical suspicion, should possibly get you to think about doing a biopsy in the nodal area where the SUV is greater than 5, if you can. So from the CLL guidelines from the BCSH earlier this year, yesterday, Piers was talking to you about frontline therapy, so the top row there. Today, I'm going to be thinking about the things in the red box underneath, so the choice of second, third line and onwards agents. And the most important first thing to say here is chemoimmunotherapy does not feature here at all. So we should just be thinking about the novel agents when we're thinking about second line therapy and onwards. Novel agents in conjunction with monoclonal antibodies. So BTKI, we have ibrutinib or acalabrutinib available to us, a BCL2 inhibitor, where we just have venetoclax available to us, and also the PI3 kinase inhibitors, which I will mention briefly. So obviously we have idelalisib available to us. And another consideration I've put down here, beware a rebound if you're stopping one novel agent to change to another. So if you have a patient who's already on a novel agent, a continuous novel agent, such as ibrutinib or acalabrutinib or idelalisib, and you think that the patient is progressing and they need to change to a different treatment, then make sure you've got all your ducks lined up first. Don't stop the novel agent they're already on until you've got a definite treatment plan and you're very sure about the need to change treatment. Because we certainly do see if somebody, for example, is on ibrutinib and we stop it to change them to venetoclax, they can get a very rapid disease progression when the ibrutinib stops. So make sure that you've kind of got as much as you can out of the novel agent that you're going to stop first. Don't stop it at first signs of progression. That might hold the patient with some level of control for some while longer before you change them onto the next treatment. So what choices are available to us? Well, I've just listed there the most sort of obvious ones, as it were: ibrutinib, acalabrutinib, venetoclax monotherapy, so venetoclax on its own, or venetoclax in combination with rituximab. And I've just put down, jotted down some of the evidence we have for the use of those drugs in the relapsed refractory setting. We're going to look at these in a bit more detail. But it's worth bearing in mind that we don't have any head-to-head studies in the relapsed refractory setting. So we don't have any studies that directly compare these agents just in these combinations on their own in the relapsed refractory setting at this time. So first of all, looking at using BTK inhibitors or Bruton tyrosine kinase inhibitors in relapse, and we'll look at ibrutinib first. And there's a lot of evidence for ibrutinib in the relapsed refractory setting, but I'm going to focus on the RESONATE study because that gives us a long duration of follow-up. And the RESONATE study looked at ibrutinib versus ofatumumab, so an anti-CD20 monoclonal antibody that we use very rarely in the setting of relapsed refractory CLL. So probably not a comparator arm, ofatumumab on its own, that we would, even think about using now. But at the timing of the study, this was how the study was designed. So I'm not going to focus on the ofatumumab arm at all. I'm just really looking at what was achieved with the patients who were on ibrutinib. Now, this was a very heavily pre-treated set of patients. So just looking at my red boxes here, you can see that over half of the patients had had 3 or more lines of prior treatment. 86% in the bottom red box, 86% of the patients in the ibrutinib arm, which is the middle column, had a high-risk genetic feature at the time of starting the ibrutinib. So either a 17p deletion or mutation, a del11q, which equates to an ATN deletion, which is another high-risk feature, and or unmutated IGHV status. So a really heavily pre-treated high-risk population of patients. And we have 6 years of follow-up in the RESONATE study, looking at these patients being treated with ibrutinib. And just looking at the progression-free survival of these patients, the median progression-free survival for these patients being treated with ibrutinib was 44.1 months. That's sort of looking at all of the patients on the left-hand side. In the right-hand side Kaplan-Meier curve, you can see where they've just selected out the high-risk patients. But given that that was over 80% of the whole patient population, the median progression-free survival reflects that of the whole patient population. So 44.1 months progression-free survival with ibrutinib. If we look at those high-risk features one at a time, you can see here in this Kaplan-Meier curve, the yellow line is the mutated, so better risk mutated IGHV patients. The grey line are the unmutated, so the worse risk or worse prognosis, unmutated IGHV patients. And you can see that those lines essentially overlap. So the IGHV status doesn't seem to affect the progression-free survival in these patients treated with ibrutinib. How about del11q and 17p disruptions? Well, if we look at del11q first, so that's the blue line. And then if we also look at the green line, which are patients with neither a deletion of 17p nor a deletion of 11q. So the blue line, the del11q, does not seem to be affected. Ibrutinib does not seem to be affected by the presence of a deletion 11q. So the del11q patients are doing just as well. The del17 patients, it's interesting. There doesn't seem to be much difference here between the patients with a del17p compared to the green line where patients had neither a del17p nor a del11q. If we go on to another curve from the same paper where we look specifically about just at the 17p, so del17p or a TP53 mutation or both. So you can see the green line where patients have neither a deletion of 17p nor a TP53 mutation, they're clearly doing the best. Once you add in either or both of a del17p or a TP53 mutation, the presence of a del17p or P53 mutation does seem to have an adverse impact on the effect of ibrutinib. So looking altogether at this data that we have on ibrutinib in these relapsed refractory patients, we're looking at a very heavily pre-treated high-risk group of patients in this study. And with 6 years follow-up, we see a median progression-free survival of 44.1 months. Neither the IGHV status nor the deletion 11q seem to affect the progression-free survival, but the presence of a P53 mutation or a del17p does seem to adversely affect the progression-free survival. Now looking again at a different BTKi now in relapse. So we're now looking at acalabrutinib. And we have 2 good recent studies which will give us some information about acalabrutinib in the relapsed refractory setting, the ASCEND study and the ELEVATE-RR study. We're going to look at the ASCEND study first. Okay, so these are patients who were treated with either acalabrutinib or physician's choice. Now, the physician's choice could either be bendamustine rituximab, so chemoimmunotherapy. So we've said we wouldn't use that now in a relapsed refractory setting, or idelalisib rituximab. But we're going to focus on the outcomes with acalabrutinib, just giving us the information about how patients treated with acalabrutinib do in this relapsed refractory setting. Now, this isn't quite such a heavily pre-treated patient population as in the Resonate ibrutinib study that we were looking at before. So you can see here that only 20% of patients have had 3 or more lines of treatment. Similar to the Resonate study, it's important to note that if you look at the prior therapies at the bottom, in the bottom red box here, none of these patients have had a previous BTK or PI3 kinase inhibitor or venetoclax previously. So if we go on to look at the median progression-free survival in these patients treated on acalabrutinib, and you can see a median progression-free survival in the reddish purple line on the top of 63% at 36 months. This data was presented at ASH at the end of last year. In the paper in JCO the year prior, just looking, this gave us some more information, sort of dividing the patients up according to their risk groups. So in the top Kaplan-Meier curve, we're looking at the effect of p53 disruption, and in the bottom, we're looking at the effect of the IGHV status. So I'm not looking at the investigator's choice lines or arms here at all. I'm just looking at the red and blue lines because I'm just interested in how these high-risk features affected acalabrutinib, okay? So if we look in the top Kaplan-Meier curve, we can see the red and the blue line, which is patients treated with acalabrutinib either with or without a p53 disruption. The 2 lines overlap. So the p53 disruption does not seem to be affecting the outcome here for patients treated with acalabrutinib. And similarly, in the bottom Kaplan-Meier curve, the IGHV status in the red and blue lines does not seem to be affecting the outcome of patients treated with acalabrutinib. Now going on to the other relapsed refractory acalabrutinib study that I said we'd talk about. So this is the Elevate RR study, relapsed refractory, the RR. And this is really interesting because it's actually giving us information about acalabrutinib in a direct head-to-head against ibrutinib in the relapsed refractory setting. So we can see here that there were about 45% of patients with a 17p deletion, nearly 40% of patients with a mutated p53 status. Well over 80% of patients had an unmutated IGHV status. So again, poor risk set of patients. But again, looking at the bottom red box, none of these patients have had previous BTKIs or venetoclax or other B-cell receptor inhibitors, so they haven't had a PI3 kinase inhibitor. These are all patients who've just been treated with chemoimmunotherapy in the past. A few patients treated with Campath there as well. And this is a really interesting study because this shows us that acalabrutinib and ibrutinib are giving us equivalent efficacy. I said at the start there are no head-to-head studies in these novel agents in the relapsed refractory setting. This is the exception. I guess what I mean there is there are no head-to-head studies at the minute to show us the difference between a BTKI versus a venetoclax or venetoclax rituximab head-to-head in the relapsed refractory setting. But we do have this study, and it does show us that acalabrutinib and ibrutinib have equivalent efficacy in this group of patients. So now we're comparing a dotted line with a dotted line and a solid line with a solid line. So we're again just sort of separating out some of the higher risk groups of patients. So the solid lines, red for acalabrutinib and blue for ibrutinib, are the 17p deletion. And you can see that those lines are essentially overlapping each other. So acalabrutinib and ibrutinib are having equivalent efficacy in patients with a 17p deletion. And similarly, in the red and blue dotted lines, the del11q lines, patients treated with acalabrutinib and ibrutinib are having similar outcomes in the presence of a del11q. So acalabrutinib and ibrutinib seem to have equivalent efficacy in these high-risk patients. And this is a forest plot, which is just looking at all the different subgroup analysis, looking at age, stage, bulky disease, number of prior therapies, and high-risk genetic features. And you can see that acalabrutinib and ibrutinib are essentially equivalent in all these settings. So this is just to summarize a little bit of what we've looked at so far. So this is BTKIs, either ibrutinib or acalabrutinib in the relapsed refractory setting. And it's given us pretty consistent data there. We have the longest follow-up in the ibrutinib Resonate study with follow-up of 6 years and this median progression-free survival of just over 44 months. We can see in the Elevate RR study comparing ibrutinib and acalabrutinib, but with a bit longer follow-up, that's going to look like probably similar sort of progression-free survival that we saw in the Resonate study. And then acalabrutinib with shorter follow-up in the Ascend study with a 63% at 36-month progression-free survival. We're now going to go on to look at the BCL2 inhibitors in relapsed refractory CLL. So obviously we just have access to Venetoclax here in the UK. And I'm going to focus on the Murano study because we have quite a lot of long follow-up in the Murano study of relapsed refractory patients treated with venetoclax in combination with rituximab. So Murano study randomized patients to venetoclax in combination with rituximab versus bendamustine rituximab, so a chemoimmunotherapy line, which obviously we wouldn't use these days as a comparator arm in the relapsed refractory setting. And one of the really interesting, important things to think about here is that this is fixed duration venetoclax. So up until this point, we've just been thinking about using venetoclax indefinitely. But as you would have seen yesterday in Piers Patton's talk about venetoclax in combination with obinutuzumab, fixed duration venetoclax there for 1 year. Here in the relapsed refractory study, we have venetoclax for 2 years, fixed duration, alongside 6 months of rituximab. So in terms of the patient population, so roughly 400 patients in this study, under a quarter had 3 or more lines of treatment. We can see that roughly just under a quarter of patients had a 17p deletion or mutation present, or possibly both. And we can see that over half the patients had an unmutated IGHV status. Similar to the studies we've looked at before, only 5 patients, so really very, very few patients have had a novel agent previously, such as a B-cell receptor inhibitor previously. So in the follow-up published in 2018, we could see straight away the improved efficacy of venetoclax and rituximab compared to bendamustine rituximab in these patients. And in an update in 2022 published in Blood, here we can see in a supplementary figure the time to next treatment, which is obviously a very useful thing to think about, because as we said right at the start, progression after a previous treatment doesn't necessarily mean the patient needs to start a new treatment straight away. The time to next treatment can be longer than the progression-free survival. So we can see here time to next treatment of nearly 5 years in the venetoclax rituximab arm. That's 5 years, taking into account the 2 years of treatment that they've had at the start. So the 2 years of fixed duration venetoclax in combination with rituximab, and then roughly 3 years after they've finished of median time to next treatment. And here, looking at this forest plot, you can see that patients from all of the different risk subgroups, age, number of previous therapies, genetic high-risk features, IGHV status, all patients in all risk groups derive benefit from venetoclax and rituximab over bendamustine rituximab. And this publication essentially led to the approval of venetoclax and rituximab by NICE in February 2019. So we've had access to this combination for about 3 years. Now, looking at venetoclax and rituximab, when we look, as we have done already with the BTKIs, how about if we now look at splitting the patients up into their high-risk groups? And we can see here that while we know that venetoclax and rituximab in the high-risk groups gave benefit over bendamustine rituximab, if we just look at patients only treated with venetoclax and rituximab but divide them up according to the high-risk features, you can see that there is a significant p-value dividing the patients between mutated and unmutated IGHV status and the presence or absence of a p53 disruption. So here with venetoclax and rituximab, the high-risk patients aren't doing quite as well as their non-high-risk counterparts. So a little bit of summary here for venetoclax and rituximab in relapsed refractory CLL using venetoclax for a fixed duration of 2 years. We have a median progression-free survival of 53.6 months, and we saw that the time to next treatment was nearly just about 5 years from the start of their 2 years treatment. But adverse genetic features possibly do have a more adverse effect on the outcome of progression-free survival. So this is really just to summarize what we've looked at so far. But bear in mind, these studies that we've looked at, really very few of these patients, and in some of the studies none at all, have had any prior exposure to a novel agent, either a BTKI or a BCL2 inhibitor. So we've said that we're looking at what our choices and considerations of relapsed refractory therapy are in the second and third and further lines of treatment, where my big red arrows are there. And in practice, that means we're going to be looking at patients who've already been exposed to novel agents, either Ven-O in the front line or a BTKI in the front line, or they've been exposed to one of those novel agents in the second line, and we're now looking at third line treatment. But all of those studies we've looked at really have been looking at these patients with the blue arrow, patients who've essentially just been treated with chemoimmunotherapy. So that means in terms of our decision making and our evidence base for deciding about sequencing novel agents and what needs to come after what and in what order, we don't have a lot of prospective evidence at all to make those decisions at this stage. So in these little diagrams here, if we go left to right for each of the rows, we might have patients who've been treated historically with chemoimmunotherapy, so they fit into the studies we've already looked at. Should we be giving them a BTK or a BCL2 inhibitor first, and then do we swap over and go to the other one afterwards? But what about the patients who've had venetoclax and inotuzumab first? What do we do with them in the second and third line treatment, and what order do we use our novel agents in there? So as I said, we have very little prospective data to guide us on this. We do have a small prospective study of venetoclax in patients who've been treated previously with a BTK inhibitor. So this is from Lancet Oncology in 2017, 127 patients with relapsed refractory CLL. 91 of them had had a B-cell receptor inhibitor, either a BTKI or a PI3 kinase inhibitor as their last prior treatment. And then these patients then went on to have venetoclax. And there was an overall response rate of 65% with an estimated progression-free survival at 12 months of 75% in this publication in 2017. So this does indicate that venetoclax does work in a population of being treated previously with a BCR inhibitor. Some updated data from the same prospective study in 2019 demonstrates that patients treated earlier on do seem to do better. So if we look in the histogram on the left-hand side, taking the sort of bracketed off bars of the overall response rate, which is the dark blue, the orange, and the green. In the right hand of the two bars, these are patients who've only had one prior B-cell receptor inhibitor, and you can see they have a better overall response rate than the left bar, where patients had had more than one prior B-cell receptor inhibitor. So probably not surprisingly, patients who've had fewer previous novel agents do seem to do better when they then start on venetoclax. And we can see a similar evidence in the Kaplan-Meier curve on the right, where we're looking at progression-free survival. So the blue line being patients who've only had one prior B-cell receptor inhibitor compared to the green line where they've had more than one prior B-cell receptor inhibitor. Similarly, Toby Eyre has published some real-world data that many members of the UK CLL Forum and other CLL doctors around the country contributed to. This also showed poorer outcome on venetoclax in patients who'd had more lines of novel agents previously, and also if they'd had progressive disease on their previous B-cell receptor inhibitor treatment, which again is not surprising. It's probably what you might expect to see. So in this population of patients, 48% had a p53 disruption. You can see that 60% had a previous BTKI, most commonly ibrutinib. 25% had a previous PI3 kinase inhibitor, usually idelalisib, and 10% of the patients had had both of those drugs. And you can see in the Kaplan-Meier curve underneath PD, progressive disease. So if patients had had, in the solid line at the top, they'd not progressed on their previous B-cell receptor inhibitor, they had a better progression-free survival than the dotted line, which are patients who had progressed on their previous B-cell receptor inhibitor. And this is a nice figure from a paper in Blood in 2019, which looked at a pooled analysis from 4 early venetoclax studies. In 3 of those studies, venetoclax was given as monotherapy, and in the 4th study, it was given in combination with rituximab. And this just gives us an idea of some of the adverse features that might cause patients to have a poorer outcome on venetoclax. And one of them, in keeping with Toby Eyre's real-world data, being refractoriness to a previous B-cell receptor inhibitor, and also genetic features, a del17p or p53 mutation. So that was a bit of information about using venetoclax in patients who've had B-cell receptor inhibitors previously. What about patients who've had venetoclax before? Can we give them venetoclax again? Well, this is some data from the Murano study. So we've already talked about the Murano study, venetoclax and rituximab in combination in relapsed refractory patients. In that study, in the publication in 2022 in Blood, 67 patients went on to progress after the venetoclax rituximab treatment. 32 of those patients were retreated with a venetoclax-based treatment. 18 patients were now given treatment with a BTK inhibitor. You can see 100% overall response rate in the patients treated with a BTK inhibitor, overall response rate of 72% in the patients retreated with venetoclax. So you can see we are getting responses with venetoclax retreatment in patients who've progressed after venetoclax rituximab. And I think that's really important. These are obviously only small numbers, but this is obviously something very important to think about, given that a lot of our patients now will be having frontline venetoclax-based treatment in the form of venetoclax and obinutuzumab. And what about giving a B-cell receptor inhibitor after venetoclax? So the other way around to what we've just been looking at. So there's a study published in 2020, which is a large retrospective study of over 300 patients. These were patients who had all discontinued venetoclax between 2014 and 2019, some for toxicity, some for progressive disease. This is a large international retrospective study. Of those 326 patients, 188 of them went on to have another line of treatment. So the study was having a look at the outcomes for those 188 patients who had to have another line of treatment after venetoclax. Over 60% of the 300 patients had had a previous BTK, 20% had had a previous PI3 kinase inhibitor. And the majority of the patients had had a line of treatment prior to getting to venetoclax. So what happened to the patients who went on to have another line of treatment after venetoclax? Well, if we focus on the top red box first of all, so this is patients who've had venetoclax before and have now gone on to have a BTKI. We said that some of these patients had already had a BTKI in the past. So if we look at the Kaplan-Meier curve in the top right, which is B, so this is looking at patients who go on to have a BTKI again. So they've had a BTKI before, then they've had venetoclax, and they've been collected in this study because they've had to stop venetoclax, either for toxicity or progression. And now they're having a BTKI again. And in the top line, which are patients who previously discontinued their BTKI because of adverse events or toxicity, you can see that they do better than the patients who previously discontinued their BTKI because of CLL progression on the drug, which again is probably not surprising and very much in keeping with a lot of the real world data that we've seen over the years in terms of progression on previous novel agents. Interestingly, in the top left Kaplan-Meier curve A, so these are patients who've progressed on venetoclax and are now treated with a BTKI, and they've never had a BTKI previously. I'm always a bit interested that that curve doesn't look quite as good as I might expect it to, but it does show us that we're getting responses in these patients retreated with BTKI, but they are relapsing again. The bottom left, patients who are treated with a PI3 kinase inhibitor after their venetoclax don't seem to do as well as those top two curves, patients treated with a BTKI. So, sequencing. There are no absolute answers here because we're mostly looking at retrospective data. And as Piers Patton will have spoken about yesterday, some of this is looking at the data and the disease factors, some is looking at patient factors and lifestyle factors. We really have, in terms of looking at venetoclax after a previous B-cell receptor inhibitor, such as a BTK, ibrutinib, or acalabrutinib, or a PI3 kinase inhibitor, we have a small prospective study, which I've shown you, and several retrospective studies, which do indicate venetoclax is effective after a previous B-cell receptor inhibitor. But patients are likely to have poorer outcomes when they're treated with venetoclax if they previously progressed on their prior B-cell receptor inhibitor or if they have high-risk genetic features. In terms of treating with a B-cell receptor inhibitor after previous venetoclax, again, this is an effective line of treatment. BTKI does better than PI3 kinase inhibitors in this setting. And again, as we've seen above when we're retreating with venetoclax, if patients have progressed on their previous B-cell receptor inhibitor, that does predict a poorer outcome. This figure is from the BCSH CLL guidelines from March this year. So I'll give you a moment just to look down that. So this is giving some suggestions of, in the left-hand column, of what the patient might have been treated with before. So if we jump right down into the second section, venetoclax obinutuzumab, because we're going to have a lot of patients who've had venetoclax obinutuzumab before in the coming years, because obviously we're now using that as one of our most common frontline treatments. So in that setting, we do have the option of using a PI3 kinase inhibitor, but the three asterisks are telling us that a BTK or BCL2 inhibitor are the preferred options over a PI3 kinase inhibitor in this setting. And so we can either use venetoclax rituximab. We'd only use that if the patient had not relapsed on their previous venetoclax obinutuzumab treatment and had had at least 12 months remission after the venetoclax obinutuzumab treatment, or we can use a BTKI. In patients who have had venetoclax rituximab previously, so we've had access to venetoclax rituximab, for 3 years now. So we are going to be seeing patients who've had that previously and are relapsing. Well, we can use venetoclax monotherapy, though there's very little evidence, certainly no prospective evidence for that sort of approach. We can use a BTK if the patient's not had one before. If the patient has had venetoclax before and has progressed, or if the patient has had a BTK before, then we may well be looking at using a PI3 kinase inhibitor. So jumping into the top section here, patients who've relapsed after a BCL2 inhibitor and BTK inhibitor, we now might be looking at PI3 kinase inhibitors, clinical trials, and allogeneic transplants. And I'm going to talk about a little bit about that now. So this is just showing you the curves we've already seen from the Mato paper from 2020, and I'm just highlighting the bottom right box now. So these were patients, if you remember, from that large retrospective study who have progressed or had to stop venetoclax because of toxicity. What about those patients who went on to have either an allogeneic transplant or CAR T cells? Well, CAR T cells is the bottom blue line on the curve here. CAR T cells in CLL are still really only in a trial setting. And the evidence for them is still not pushing CAR T cells into not looking as promising as we know so far in the lymphoma setting, looking at CAR T cells possibly in conjunction with novel agents in the relapsed refractory CLL setting. But in the reddy brownie line at the top, allogeneic transplants, well, should we be thinking about that for our relapsed refractory patients? Well, in our BCSH guideline, highlighted here with the 2 big red arrows, we have included some guidance as to when you might consider an allogeneic transplant. So the first thing to think is my patient currently fit, or will they ever likely to be fit for an allogeneic transplant? So if your patient is very elderly at the start of treatment, then obviously you're never going to be considering an allogeneic transplant. So patients who are very elderly or who have other comorbidities, you're never going to be thinking about an allogeneic transplant because the risks of the transplant obviously going to outweigh the benefits. But occasionally we do see patients presenting in their 30s or 40s with CLL. And while we know we're getting very good durations of response with our novel agents, we still can't say we've cured CLL. And I think it's always, trying's not buying. It's always worth having this option in the back of your mind. It doesn't mean that you're committing to transplant the patient, but it's worth having the option in the back of your mind. So if you've got a patient who's on their frontline therapy, and they're now moving on to their second line therapy, if they are patients with a high risk feature, specifically a p53 disruption, and you're needing to start second line therapy in them, then you possibly need to start to think about an allogeneic transplant. You're not going to transplant them now, but you're just thinking, my patient has a high risk p53 deletion or disruption. They've already moved through 1 line of novel agent. I've got 1 more line of novel agent therapy to offer them, but what am I going to do after that? And if they're a young fit patient in their 30s, 40s, maybe early 50s, I would be thinking about referring them to a transplant team, getting them tissue typed. I don't want them transplanted now, but I want it as a back burner option. I want to know if they've got donors available for when they progress after their second line treatment. It may be at that point we have other novel agents or other combinations to offer, but we're just getting a plan in action if we need it. If your patients work through 2 lines of therapy and they don't have a p53 disruption, but they've already moved through 2 lines of therapy and you're starting them on their 3rd line of therapy and they've already been through their novel agent options and they're young and fit, then again, in those settings, I would be referring the patient and thinking about the option of a transplant and just getting it set up so that if we need to move to that, we have got an option and we know what our donor status is. In patients who are not eligible for a stem cell transplant or don't want one, which is absolutely fair enough, what other options do we have? So when patients have already progressed after a BTK inhibitor and a BCL2 inhibitor, what next? Well, there were 2 posters at EHA presented by a collaboration between Toby Ayer and Anthony Mato. These were 2 large retrospective real-world data analyses in over 300 patients each. And these were patients who'd progressed after a BCL2 inhibitor and a BTK inhibitor. And the data here was quite sobering, really. In Mato's poster, time from finishing a BCL2 inhibitor and BTKI to death or further progression, whether they had more treatment or not, was less than 6 months. In Toby Ayer's poster, the overall survival was just over a year in patients progressing after both these novel agent therapies. So what can we do if we have a patient who's progressed after both of these lines of treatment? Well, as we've said, if they've not progressed on venetoclax-based treatment previously, then we might have the option to give them venetoclax plus minus rituximab again. The acalabrutinib and the ibrutinib, you can swap them over. So if the patient has had previous ibrutinib, you can give them acalabrutinib again, as long as they discontinued the ibrutinib because of toxicity and not progression. And the same is true vice versa. You do have the option of giving them ibrutinib if they've had previous acalabrutinib and discontinued it because of toxicity, but not progression. Obviously, if you have a patient who's had toxicity on acalabrutinib, you may be concerned about giving them ibrutinib because it may be that the toxicities they had on acalabrutinib might well be a problem on ibrutinib as well. And Adrian's going to go on to speak about some of the side effects that we see in patients due to therapy. I'm just mentioning idelalisib here briefly. So I've not mentioned idelalisib really at all yet. Idelalisib and rituximab are obviously our other novel agent, which we've not mentioned yet because we've been so focused in the last few years on BTKIs and BCL2 inhibitors. And that was because idelalisib came with problems in terms of immune suppression and infections, particularly PJP and CMV reactivation, as well as quite troublesome colitis and liver problems in some patients. So idelalisib sort of fell out of favor. But I guess in patients where you've used a BTKI and a BCL2 inhibitor and you don't have another treatment option, idelalisib is an option. As we've seen already from this, the data I've already presented, we know that the PI3 kinase inhibitors don't do quite as well as the BTK inhibitors, particularly in patients who've had prior lines of novel agent therapy. In the ASCEND study, it was one of the comparator arms compared to acalabrutinib that I presented earlier. The median progression-free survival there was about 15 months in patients treated with idelalisib and rituximab. What other options do we have? I'm coming towards the end now, and I'm just going to talk about pirtobrutinib. So pirtobrutinib is currently only available to us in clinical trials, but there is now also a compassionate access scheme. Pirtobrutinib is a highly selective, non-covalent third-generation BTKI. So we've had ibrutinib, acalabrutinib, now we have pirtobrutinib. And the really exciting and interesting thing about this drug is that in a large early phase study of over 300 patients, 120 of whom had CLL, very heavily pretreated patients with a median of 4 lines of prior treatment, and all of them had had a previous Bruton tyrosine kinase inhibitor, there was an overall response rate of over 60%, even in those who had previously been resistant to a previous BTKI or had a CYS481 mutation, which confers resistance to ibrutinib. So it looks like a really interesting drug. The data was updated at ASH last year, now looking at 170 CLL or SLL patients, and the overall response rate has deepened with further follow-up with more time. So an overall response rate of 86% in those with follow-up of greater than 10 months. So how do we access pirtobrutinib in the UK? Well, we can access it through clinical trials, and it's worth noting that pirtobrutinib is available in clinical trials, also including Richter's, as well as relapsed refractory CLL. And there is also a compassionate access scheme for patients with relapsed refractory CLL. You need to note that the patients to access pirtobrutinib through this scheme, they need to be ineligible for a clinical trial of pirtobrutinib, and they also need to have had previous treatment, including the 5 possible options that we have now. So that includes chemotherapy and an anti-CD20, a BTK inhibitor, a BCL2 inhibitor, and a PI3 kinase inhibitor. So before we can access this drug, we do need to think about treating our patients with idelalisib if they've already exhausted the other novel agent therapies. So my conclusions overall, very important, no chemoimmunotherapy in the relapse setting. If you have a patient who's on a continuous novel agent and you're worried that they're progressing, think first, do they definitely need to change treatment now? Don't stop the novel agent until you're sure they need a change of treatment, and until you've got your next novel agent definitely lined up, ready to go, because you do have this risk of rebound or rapid progression when you stop the novel agent that the patient is on. Acalabrutinib and ibrutinib in that ELEVATE-RR head-to study appear to be of equivalent efficacy in the relapsed refractory setting. And then I've taken a very broad brush approach here in these conclusions to the progression-free survival, because it's very hard to keep all the sort of small numbers in your head. But if you have a sort of broad brush idea of sort of amount, times that you can roughly tell patients, I think we can think about a median of 3 to 4 years till progression in patients treated with ibrutinib or acalabrutinib. I've put there in brackets possibly longer, and that's simply because while these are obviously the study data, and so this is the facts and the evidence that we know about these drugs, We've probably all got some patients who've been treated with ibrutinib, even patients with p53 disruptions who are still on it, having started originally in a compassionate access scheme to ibrutinib 6, 7, 8 years ago. So some of those patients do seem to do exceptionally well. With venetoclax and rituximab, so looking at the Murano data in the relapsed refractory setting where we have our fixed duration, 2 years of venetoclax, 6 months of rituximab, the median progression-free survival does seem to be longer than 4 years. But note that the high-risk genetic features seem to have more of an impact on the outcome with venetoclax and rituximab than for patients treated with a BTKI. If you're looking at a patient who's relapsed and on venetoclax and now needs another B-cell receptor inhibitor, then BTKI is the preferred option over PI3 kinase inhibitor. And we do have retrospective evidence for the efficacy of going to venetoclax after a previous B-cell receptor inhibitor and vice versa. So they do work if you use one after the other. Once you've used both of those options up, your BTKI and your B-cell receptor inhibitor, venetoclax, don't forget about PI3 kinase inhibitors at this point. Think about clinical trials, accessing pirtobrutinib or other clinical trials available. Think about the compassionate access scheme we have available for pirtobrutinib. And don't forget, in your fit patients, especially if they have high-risk genetic features, in your fit young patients, don't forget to have an allogeneic bone marrow transplant mentioned to the patient, worked up, trying's not buying, have it on the back burner, just see what the options are for that. Because as you work through your second or possibly third lines of treatment in young fit patients, you might need to have an allogeneic transplant available. That's the end of my talk, so I'm very happy to join the panel for some questions. Thank you.
Thank you very much, Helen. That was amazing tour de force roundup for relapse refractory. Fantastic. So could I please invite other panelists? So we will be joined also by John Greensmith, who is our patient representative. So John very kindly will give us patient's view as well. So before I actually start, very brief question to Helen about rebound. Obviously, we've heard about rebound when we were planning to start venetoclax on somebody who is relapsing on ibrutinib. Would you do that rebound effect for venetoclax? So do you tend to run in with venetoclax, same with other idelalisib?
So certainly, as you say, yeah, we absolutely know about it with the BTKIs, don't we? And so while you said at the start that we can talk about things that are not licensed or evidence-based here, we can answer questions very sort of openly in terms of what we actually do in our clinical practice. And certainly patients where I'm swapping from a BTKI onto venetoclax, particularly bearing in mind we have the dose titration with venetoclax where it's going to take us 5 weeks to get up to full dose, then I would absolutely have some overlap. So I would keep the BTKI running while I start the venetoclax, and I don't stop the BTKI until they're up to probably 200, if not 400 milligrams of venetoclax. In the setting of swapping from venetoclax to a PI3 kinase inhibitor, I have to say I've probably not had that setting yet, so I don't think it's something I've specifically thought about. I think in that setting, I might be less inclined to do that because we know that we can combine venetoclax with BTKIs safely, because obviously there's data showing us that in the front line. So we know those two drugs can overlap and be given safely together. In the context of giving idelalisib in combination with venetoclax, I think I'd be maybe a little bit more dubious about that, but I'd certainly be keeping a really close eye on the patient when I stop the venetoclax and start the PI3 kinase inhibitor. We've certainly seen patients, you know, where things seem to take off even with the CLL appearing in places that haven't been a problem before.
Thank you. What do you do, Adrian? Do you tend to, if it's somebody on venetoclax relapsing, do you tend to run in?
Yeah, I just keep things going for as long as I can keep them going until it's not working. I mean, I think that the difficulty is it's a little bit uncharted waters, I guess, Renata, in that I probably put 1 or 2 patients on PI3 kinase inhibitors in the last 12 months or something, just because of the fact of the chronology of this, in that thankfully I've not seen a huge number of patients who are really falling off venetoclax, and they've been through that sort of treatment. I worry about it more in terms of the rebound with the BTK inhibitors, though, in terms, because as you've seen, you get a very brisk rebound when you stop those, and maybe less so with the BCL2 inhibitors. But I mean, I guess it's just the problem here is, chronology is that Ibrutinib came along when we were seeing patients becoming refractory to FCR. Venetoclax came just about the time that patients were falling off ibrutinib. What is the optimal treatment? I guess that's coming back to the end of the talk, is what's the optimal thing to do for patients who've failed both lines of therapy, because most aren't going to be eligible for transplants. And I think that although PI3 kinase inhibitors is what we've got, it's not very good treatment, and I think that anti-Mato's data, the retrospective US data demonstrates that that's the case. So I hope that what we will see, that pirtobrutinib or something else is going to come along, which might mean that this question becomes a little more moot, that we've actually got a more effective option.
Yeah,
I totally agree, Adrian. Like we start idelalisib so infrequently, don't we? But I do wonder. I've just had a couple of patients recently where I've started thinking, oh, I'm going to have to think about this pirtobrutinib compassionate access scheme, because we don't have the pirtobrutinib trials open here in Newcastle. And I thought, oh heck, well, that means they're going to have had a sniff of idelalisib first. So that does make me wonder if I'm going to have a few patients on idelalisib in the next few months, really, so I can get access to pirtobrutinib.
Just on a more general point, though, coming back, and I'd agree with you entirely there, Helen, because I've had the same thing of of getting that fifth line for pirtobrutinib. CAR T therapy, something relatively close to my heart, but it doesn't work well in, and as you've shown the data, in the context of somebody who's failed everything, who's got bulky refractory disease, then CAR T therapy can join the list of things that doesn't work. Where it does probably work, though, is earlier in the treatment pathway. And I think that what we need to be doing is being a bit smarter in terms of identifying patients who are going bad before they've gone bad. And, because by the time somebody's is refractory to ibrutinib, refractory to venetoclax, then it's almost too late, and they've got bulky refractory disease. You've got nowhere to go to there. My prejudice, though, is that, and I don't know that we can really say this is proved, though, is that some of the other therapies, be it bispecific antibodies, immunotherapy generally is going to work better if applied at an earlier time point. So I think it's whether or not we can start looking at patients who don't achieve MRD negativity on venetoclax, for example. They're definitely destined not to do so well. Murano data, as showed that. Or a patient who's got really high risk disease, with BTK inhibitors, and then thinking about whether or not we can then pick those out. It's investigational therapy, but otherwise, particularly for younger patients, they're just on a trajectory of ending up whereby their treatment becomes ineffective. And I totally agree with you that it's worth thinking about allogeneic transplantation, although I don't know how many you've done in Newcastle. We haven't pretty much transplanted anybody for CLL for the last best part of a decade, to be honest.
We've had one, but really for a young man in his 20s, and it was for CLL previously treated, and then a Richter's transformation. And he's had allo CAR T and has relapsed after both.
But maybe try and pick these people out earlier. But I think that's work in progress, and I don't have a definite solution for that. I don't know if it's uncharted territory.
So talking about young patients, so Adrian, as you kindly alluded, so there is a question from Dr. Paul Grieve. So thank you very much for posting this. So it's about the younger, fitter patient use up then obinutuzumab as a first line rather than FCR will generate cohort of patients who are more difficult to salvage with novel agents. So do you think that's the case? I've got to say, I've never thought about it like that. So thank you for opening new perspective.
I always think that I'm never sure if I'm way off left field here, but I still think in the very good risk patients, so the patients with no genetic complexity, no P53 disruption, intact 11q, etc., with mutated IGHV in a very young patient, I do still wonder sometimes about FCR just to save the novel agents for later. Only in the patients with absolutely no genetic high risk features whatsoever. And I'd be very cautious and concerned. My worry, if it was me, I'd be worried about my AML NDS risk later down the line. That would be my only reason not to have the FCR. So I think that's a really important point in counselling the patients. But I do worry about these young patients who have a chance of being cured, because we have the evidence that they have the chance of being cured. And if we use up the novel agents early, then we do run out and potentially have this more difficult to treat population.
Yeah.
Yeah.
I mean, that's not even sort of, that wouldn't even sway you after seeing the EHA data, that Ven-O frontline is so good.
I know,
But
I
I've got
know,
to
I
say,
know.
it fills me, you know, whatever you do, just give a Ven-O
And it'll all be
somewhere,
fine.
because we
Just
won't
give it
be
to
able to
everybody.
give a Ven-O second line
Yeah,
for probably
no,
10 years.
Yeah, I know. I think I just do worry about having sort of used up all the novel agents, as it were. But no, absolutely.
What do you think, Adrian?
I think our confidence will grow with longer term follow-up for novel therapies. I think the difficulty is, and I mean, I come to this in my talks, it's a bit about what I was going to talk about with toxicity, but you know, we've got a long tail of follow-up with FCR, and therefore you know what it does, both good and bad. The data that are emerging for Ven-O look better and better, but it's reminiscent. I remember sort of going back to conversations you used to have about follicular lymphoma 10 or 15 years ago, about, you know, whether or not you should use rituximab in the frontline setting, or whether you save it up for the future when they're relapsing, because for exactly the same sort of reasons. And I kind of feel that, you know, I think that the data for novel therapies in frontline setting just looks so compelling without the toxicity signal, that it's hard to think they're not going to do well. And I agree with you, Helen, entirely on the point about what do you do with the patient who's got, you know, good risk disease, but equally they're the person
They do very well as well.
that should do fantastically well with whatever you do.
Regardless, yeah, that's right.
Without the toxicity consideration. And then, I mean, it's something that then COVID comes into it as well, that, you know, that we've had access to, you know, Ven-O or acalabrutinib first line therapy have arrived about, you know, during the COVID pandemic as well, largely. I know I get asked this question now and again about, you know, whether or not we should start FCR, but I certainly think with regard to COVID, maybe things are changing now. That's just completely blunted any enthusiasm I've had for doing it, because I guess there's the AMDS AML risk, which, as you say, Helen, I think that's the thing that really worries me. But equally, it is going to cause more short-term infectious toxicity. So I don't know that we've seen the end of it. And it's one of those things that treatment goes in fashion. It's a shame that, you know, when you throw away a treatment that doesn't work, but I think we will end up just moving past it completely, and it'll become a non-question when we've got long-term follow-up for Ven-O, or indeed, you know, not just Ven-O, there'll be triplet therapy, and then of course, you know, the ibrutinib plus venetoclax. I think it's just going to become a somewhat redundant question, but we are still going to end up, given the nature of CLL for most patients, of the what do you do when things fail, and then that's going to be a problem. But I don't know it's going to be a bigger problem or I don't think it'll be a lesser problem if you started everybody on chemotherapy.
Yeah, no, absolutely.
So, Neve, can I just ask you to sort of try to tackle Dr. Kennedy's, thank you, Dr. Kennedy, for posting this question, about venetoclax in relapse refractory setting. I mean, obviously, there is a likely enrichment of higher biological risk. Do you tend to sort of think, should I give a maintenance type of treatment of venetoclax or Ven-R? What do you do?
There is a small amount of data from Anthony Mato's group that was presented at ASH last year about venetoclax, retreating someone with venetoclax who has had a prior venetoclax exposure, and about 2/3 of them respond. So I don't think it's true to say if someone has had a fixed duration venetoclax that you can't use venetoclax again. And the other, you know, as we're thinking about theoretical concerns and long-term follow-up, you know, there is data from the Australian group looking at long-term venetoclax and how it impacts on things like clonal hematopoiesis and CHIP in the, you know, in the non-lymphoid population of the bone marrow. So we don't have any evidence that people on long-term venetoclax are more likely to get CHIP long-term, but I have that concern, and that's slightly, you know, would lean me towards a fixed duration venetoclax rituximab. My experience from the clinical side is that, you know, if patients, you know, get to vote in this, and I definitely think they should, they do tend to vote for a fixed duration therapy.
Yeah, that's actually a very good point. I sort of the CHIP is a bit of a concern. Sort of moving on to next question, Neve. So I mean, there is a question from Dr. Eman. So Is there a point to check for TP53 if we're giving targeted therapy?
Yeah, I mean, it doesn't, I suppose, knowing whether a patient has a TP53 mutation or not in the relapse setting doesn't, I suppose, play a major role in choosing whether they get a BTK or a BCL2 for me. I mean, it will be a lot around patient factors influencing that decision. It does, however, change how I counsel them in terms of what they might expect in terms of duration of response and likelihood of response. So that, for that reason, to sort of do proper informed consent, we get as much information as possible. And I do test for TP53 in before each line of treatment. And that's still what the International Working Group for CLL recommends.
Yeah. So can I bring John in? So John, if I could sort of, if that's okay, to reveal your past medical history here, sort of in this wide forum. So John is a CLL support exec, but also obviously he's been tackling with CLL for over 35 years, and you've been around. You basically had every single treatment known to man. So all the treatments which Helen sort of listed, you had them. Yep. Now, can I sort of ask an elephant question? And I'm afraid to ask, but everybody's probably thinking, what's your thought? You're currently on Venetoclax. Obviously, you were on ibrutinib before. You are in remission. What's next? How do you feel about the next?
Okay, if I go back a little bit before I answer the question directly, in 2013, I had an autoimmune hemolytic anemia, and it was a very dark place because at that time, the real options for me were few and far between. And thankfully, ibrutinib access scheme came along, and that was life-saving. To be honest with you, at that point, I would have grabbed anything that was available because from my perspective and my personal circumstances, the options were effectively nil. Now that I've had to go on to Venetoclax in April 2020, and I'm well on it, I'm really fascinated by Helen's summary that I still have options. And from a patient's perspective, to have options is phenomenally reassuring. Then looking at the options with your consultant, depending upon your situation, whether you're TP53 or 11q, whatever it is, and understanding from a patient's perspective the impact of that and how that affects the decision making. I mean, a couple of times I've been at the famous, well, if I use the musical analogy, crossroads. You have an option, one of which is the highway to hell, and the other option is the stairway to heaven. So and trying to make that decision with your consultant is challenging, but that's when shared decision making really becomes very effective.
Yeah, no, thank you, John. A question sort of to all, I don't know who want to pick it up. So from Dr. Anonymous Attendee, thank you for posting this. In the relapsed TP53 mutation with no previous exposure to BTKI, acalabrutinib is preferred. Right or wrong? Now, I'm kind of thinking about this as obviously acalabrutinib it's a tighter spectrum of kinase inhibitors. Ibrutinib, broader. We know that, for instance, ibrutinib, because of this broader kinases, is better for GVHD. I mean, do you have? Do you have opinions? Should we go for ibrutinib or acalabrutinib? This is the patient who does not have any cardiac issues. So from biological point, what would you go for?
You only get the benefit or supposed benefit of ibrutinib's broad target of action if you're able to stay on drug and tolerate drug. And if we're dealing with majority of people in their 70s, they do come with cardiac histories and tolerability issues. So I mean, my practice is certainly to use acalabrutinib ahead of ibrutinib for patient tolerability, and you have patients staying on an effective treatment longer.
Yeah. Adrian and Helen, yeah, Adrian, you're putting hand up.
I'd agree entirely. I mean, I think that this is where the data that Helen's already shown from the Elevate RR's trial it doesn't address this in the frontline setting, but in the context of relapsed refractory disease, the response curves for ibrutinib versus acalabrutinib were superimposable. So, and I think that it's hard to think there'll be something that will be seen differently in the frontline setting. The things that get pushed out, that we don't have the follow-up data for acalabrutinib that we have for ibrutinib, but again, I think that with more data and more follow-up, that we'll get greater confidence in using second-generation BTK inhibitors in this setting. The other question that sometimes comes up, I suppose, is then in the frontline setting as to whether you use a BTK inhibitor or Venetoclax for untreated patients with what's the optimal treatment for patients with high-risk disease, and whether extended duration treatment is superior. Is it a Veno versus acalabrutinib question? And there is some school of thought, I'm not sure, brought to you by AstraZeneca, that would suggest that acalabrutinib is superior. I think that with regard to that question, it depends on how well you respond, and that's the difficulty of knowing whether you're going to get MRD negativity. So if you fail to achieve MRD negativity with Veno and you've got a p53 deletion in the frontline setting, you're destined to do badly. But and therefore playing the percentages of BTK inhibitor may be a preferable treatment, because it's not predicated on MRD elimination for success. But so I think, again, personally speaking, I'd use acalabrutinib, because I think my take on it in prejudice is equipoise for activity, and given the fact that there's a clear signal suggesting better tolerability, that it's the treatment to go for.
Yeah, no, thank you. I think we're eating obviously to our coffee break, but as we started, I think it's worth, the questions are excellent, so I think let's rattle through the questions. Another questions from anonymous attendee about pirobrutinib, so Loxo. So for the patients who have not received chemoimmunotherapy, so obviously they will. What's your thoughts about that?
I think that's going to be a very rare patient that has been through numerous lines of targeted therapy and is still fit to receive chemoimmunotherapy. I mean, we in Oxford, we've had the Loxo trials open for a number of years now, and it's a very well tolerated drug, and certainly would, if you're trying to compare the tolerability of Loxo with the tolerability of something like FCR or bendamustine, it's apples and oranges. They're really a very different proposition to face to a patient.
But I presume currently there probably, as you rightly say, would be difficult to find a patient who went through all the inhibitors and have not had chemo, unless they are sort of early trials type of patients.
So maybe someone who got ibrutinib on a study as first line, and maybe we'll see this, as the flare cohort matures and they, finish their ibrutinib and come off and potentially.
So as currently stands, do they have to have failed chemoimmunotherapy to go for Loxo?
So there's 2 studies open at the moment. One is for progression after so people needing a second line treatment, and that's a randomization between rituximab and venetoclax, and rituximab, venetoclax, and Loxo or pirtobrutinib. And then the other study that is open is a single agent long, so that's a fixed duration trial. The other study is sort of, they can have to be BTK exposed, either intolerant or resistant to it, and they have to have been exposed to a BCL2 inhibitor. I don't think they have to have had, knowing the patients that are on it, they don't have to have been exposed to idelalisib.
So it's just the compassionate access scheme where they have to have been through all their lines of treatment. But if they can access the trial, then they don't need to have had all of those lines.
Yeah, yeah. And
I think, sorry,
yeah,
I was going to say,
go on.
Under that circumstance, it's probably one, if you really had a patient like that, it's a conversation to have with Lily, in that whether or not you get any, because going back to getting chemotherapy would clearly be an ineffective and toxic toxic thing to do. Whether they would be swayed by that, I don't know. But as Neve said, I think it's tiny numbers.
You'd hope that they would. You'd hope that they would be swayed by it. I did ask them about a patient who'd never had idelalisib and otherwise was going to fit the criteria for the compassionate access scheme, and she did have some bowel history, and I didn't want to give her idelalisib, and they weren't swayed by that. Unfortunately, for the compassionate access scheme, they wouldn't accept her without idelalisib first.
Right. So that last quick question and kind of fire answers from Dr. Norris. Sorry, I'm not going to try and butcher your surname. Do apologize. So high-risk patients. Adrian, you already kind of touched on it. What would you sort of, do you go more for the BTKI or Venetoclax?
As I said, I think before, I think probably BTKI on balance, only on the basis that you've got extended duration of therapy and uncertainties about MRD negativity. But I don't know that overall we've got data to really say that there's superiority of one approach to the other. If you look at their overall how they do in the long term, you may get a better for duration of first remission, but it probably doesn't. It might all end up getting to the same point eventually.
Yeah. Okay. No, I think that's difficult to disagree. Thank you, Adrian. Right. So sorry, I've eaten to your break, but I think it was very important to clear all those questions